Hello everyone. Today I'm presenting an analysis of heart disease and lifestyle risk factors using data from the CDC's behavioral risk factors algorithm system. Heart disease continues to be the leading cause of death in the United States, accounting for roughly one in every four deaths. My central research question is what life factors and more importantly, what combinations of factors drive the greatest risk for heart disease. To answer this, I examined several key variables, including BMI, physical activity, smoking status, and alcohol consumptions. What I found revealed some striking patterns about how these risk factors interact, and I'm excited to share those findings with you today. So here we can see a heat map comparing the general health with the age category. Uh, Resulting in the more aged adults have a high risk of heart disease rather than younger adults. So moving on, moving on from this to the life factors that affect heart disease in American adults. So we have uh, to examine what happens when we look at lifestyle as a composite score that combines multiple health behaviors into a single metric. This line chart reveals a striking pattern. As lifestyle scores worsen, meaning people engage in more unhealthy behaviors, we see heart disease cases increases dramatically. Notice how the line peaks around a lifestyle score of 35,000, where we observe over 5,400 cases of heart disease. This steep upward climb at higher scores is particularly important because it suggests there's a tipping point in the relationship between lifestyle choices and cardiovascular risk. Once individuals across a certain threshold of accumulated poor health behavior, their risk doesn't just increase gradually, it accelerates rapidly. This pattern has significant public health implications. And the critical question this raises is whether we can identify the people who are approaching the tipping point and intervene with targeted programs. So then we're moving to the multiple risk factors. So here, let's start by looking at how different combinations of risk factors affect heart disease prevalence. This horizontal bar chart displays four distinct risk profiles that combine BMI status, physical activity levels, and smoking behavior. At the top, we see the highest risk group, individuals who are obese, physically inactive, and current smokers. This group shows an 18.8% heart disease prevalence rate, meaning nearly one in five people in this category have heart disease. When we compare that to the second bar, overweight and inactive individuals at 13.8%, we can see that obesity adds considerable risk beyond just being overweight. What I find particularly interesting is the third bar obese individuals who are active smokers show 11.5% prevalence. This suggests that physical activity may buffer some, though certainly not all. So moving on to the dashboard, combined combined of multi-risk profile, lifestyle score, and comorbidity burden. Heart disease rarely exists in isolation, and this visualization helps us understand how the presence uh, the presence of other chronic conditions led to cardiovascular disease. The horizontal axis shows the uh, number of other chronic diseases people have, and the bars are diseases people have, and the bars are color based by age group, so we can see how this relationship uh, varies across the lifespan. This finding supports the value of integrated care models that address multiple conditions simultaneously rather than treating each disease in its own silo. Moving to BMI category and diabetes, which affects heart disease, this is where the analysis gets really interesting and it challenges some common assumptions when it comes to heart disease risk. Obviously, the whole story, these group bars compare heart disease rates across different BMI categories. Each category is split by diabetic status. The blue bars represents non-diabetic, orange is the diabetic, and with the red with the overweight, light green with the obese. So, what's critical and often overlooked is even among individuals at normal weight, having diabetes significantly. Some comparisons, normal weight diabetics shows higher rates than overweight non-diabetics. This challenges the tendency to focus cardiovascular prevention efforts primarily on weight loss and reminds us that metabolic health is multidimensional. So moving on to the alcohol use patterns and sleeping patterns. So we have the visualization, which is somewhat more exploratory in nature, and it examines how alcohol consumption patterns relate to BMI categories like normal weight, obese, overweight, and underweight. The top panel shows the percentage, while the bottom panel uh, the bottom panel shows displays the actual case counts. What we observe is across BMI groups and also show interesting variation by how much sleep people report getting. While the relationships here are complex and require further investigation to fully understand. This chart highlights an important principle. Health behaviors don't occur in isolation. These are questions that deserve more focused research, but they remind us that when we think about heart disease prevention, we need to consider the full constellation of lifestyle factors, how they interact, not just individual risk factors in isolations. So it's a dashboard combined with heart disease, BMI, and comorbidities. So we have the smoking status against the age and sex. So let's turn our attention to smoking and ask, does tobacco use become more dangerous as we age? This stacked bar chart breaks down heart disease prevalence by smoking status across different age categories among adults aged to 70 to 74. Current smokers show approximately 50% heart disease prevalence compared to about 35% among non-smokers. That's a 15% point difference, which represents a substantial elevation in risk. But when we look across all the age groups in this chart, uh, we see that the relative difference between smokers and non-smokers remains fairly consistent throughout the lifespan. This tells us that smoking doesn't just become harmful in our older adulthood, it's damaging at every lifestyle age. So the public health takeaway here is that tobacco cessation efforts should be aggressive. So we have and why it deserves continuous investment and emphasis in clinical practice and public health programs. So for conclusion, so let me bring this all together and answer the question. What's the most effective approach to preventing heart disease? Based on this analysis, I want to highlight three critical findings. First, multiple risk factors don't simply add together, they multiply. We saw that obese, inactive smokers face nearly double the heart disease risk of individuals with fewer concurrent risk factors. This multiplicative effect means that addressing multiple risk factors simultaneously can produce outsized benefits compared to single factor interventions. Second, diabetes is as powerful as predictor of heart disease as obesity itself. We cannot afford to ignore glycemic control in cardiovascular prevention, and we must recognize that diabetes drives a risk independently of someone's weight, body and weight. Uh, the third, smoking remains highly modifiable and powerful at every age. Cessation programs deserve our continued investment because they can reduce risk across the entire adult lifespan. The implication these findings is that single factor interventions miss the bigger picture. Telling someone to just lose weight or just quit smoking or just exercise more uh, just may not be effective as we would hope. What we need instead are multifactorial approaches that simultaneously address weight management, physical activity promotion, tobacco cessation, and integrated chronic disease care. Population health strategies that tackle these combined risk factors together rather than addressing them one at a time may achieve far greater impact in reducing the burden of cardiovascular disease. So thank you for your attention.